Hi, I'm Dr. Rob Noecker here in Fairfield, Connecticut, Ophthalmic Consultants of Connecticut with Dr. Jim Thimons. And today we're going to talk about the patient with ocular surface disease and glaucoma.
Ocular surface disease has been an integral part of refractive and cataract surgery for at least the last decade. A great deal of attention has been brought to its impact on surgical outcomes, visual performance. In the glaucoma space, it's a much more recent arrival. In the last 5 years or so, we've seen a marked uptick in the awareness of clinicians as to why the ocular surface is important, and then additionally, how it can impact both the visual and the quality of life outcomes of the patients being treated, and maybe more importantly, downstream, how it changes outcomes in ocular surgical intervention.
I agree with Dr. Thimons. So I think what's changed is a growing awareness, because once again, it's been more obvious in the areas of cornea subspecialties, but as it happens that these patients tend to run together. The older demographic makes it more likely you have glaucoma. It also makes it more likely you have ocular surface disease. And there's a number of prevalent studies which have demonstrated that patients with glaucoma have a higher rate of ocular surface disease, or higher than the general population. And there's probably a few reasons for this. Number one, what we do in terms of therapy, and we'll talk later about this, probably makes a lot of ocular surface disease worse. And also, these patients are just more prone. The patients who are more prone to have problems with therapy probably already have pre-existing ocular surface disease. But now we have new technologies both to help us diagnose, and if we find the patient with ocular surface disease, we can change or kind of modify our treatment algorithm to better customize it for that patient who's more likely to have problems.
So if I see a new glaucoma patient on a referral and that patient has any kind of symptomatic complaint regarding ocular surface, I'm going to make the workup a relatively parallel entity. We evaluate all the metrics in glaucoma, and then we evaluate the metrics within ocular surface. I will literally choose the pathway that I'm going to apply next based on the magnitude of the ocular surface disease, the patient's symptomatology, and the level of glaucoma. Recently, the LIGHT study has shown, I think, a very clear indication that laser as a first-level procedure, a first-choice procedure, is an excellent choice. And that has mitigated a lot of my decision-making in the last several months in patients with ocular surface issues, because I know that they will be made more complex eventually with topical therapy. And if we can avoid topical therapy or at least delay it, there's an opportunity to treat the ocular surface and then subsequently utilize medications maybe after a laser down the road in several years.
I think what's different is how we manage these patients, because we're all aware that as the baby boomers are kind of approaching this age now where they're basically at glaucoma patient age. You know, they're starting to get cataracts, they have glaucoma, their rate of ocular surface disease is increased. So we have an increasing demand for our services to address the problems of all these patients. And I think for that reason, we need as many eye care providers as we can, screening through these patients and evaluating who is at risk for each problem. But I think the important concept here is that in the past, I think we've often siloed it. We said, this patient has glaucoma, he just needs his eye pressure lowered. And that's all you worry about. That's what you kind of forget about every other issue. Or in the past, this is a dry eye patient, we're going to treat his conjunctiva and his cornea and outside his eye, and that's what we're going to concentrate on. But I think now we're able to be much more holistic in our approach, and that's the nice thing about working here in this practice with Jim, is we're really take a very holistic approach and address all the issues that individual may have. Starting with the ocular surface disease, if he has glaucoma, we can decide if medical therapy, and if it is medical therapy, what's the best medical therapy? Do we want to minimize his preservative exposure? Do we want certain active ingredients like prostaglandin analogs may be more deleterious to the eyelids than other drugs? So now we can do surgical options that we have with MIGS therapy, SLT. So we have a whole plethora of choices, and really going through and sorting through is essential. And so, as Jim was saying, ordering these tests early on, getting kind of a basic format of information from that patient, I think is very important, and then we can move forward depending which therapy path we choose to take.
Up until probably the last 5 years on a broadly used basis, nobody was really assessing ocular inflammation. Inflammatory joined the armamentarium of ocular vital signs, which we now utilize on almost literally a daily basis, an hourly basis within the practice, to assess ocular surface status. So we look at inflammatory or MMP9 to assess levels of inflammation and presence of inflammatory cellular activity. Additionally, we also take a look at the tear film, make sure that the tear osmolarity is within normal range, or if not, how that complements or enhances the ability to understand the relationship between that and inflammation. Eventually, though, the bottom line is the ocular surface becomes a vehicle for us to either lose compliance if we're not managing it well, to change the visual performance of the patient, and many patients complain about poor acuity because of ocular surface issues. They already have a little bit of a cataract, they may have some macular changes. So we need to optimize the external surface to maximize the residual visual performance capacity. And then the final piece is, at the end of the day, after 5 or 10 years of management, if the patient ends up in surgery, and it's highly likely that if they live long enough, they will move through medication, a good percentage, and move into surgery. I want the surface to be as pristine as possible so that when Rob sees them, he has the best opportunity to maximize his outcomes from a surgical perspective.
So I think, we've all realized that inflammation's actually the problem in ocular surface disease. I mean, this research has been around since, the early studies on cyclosporin, one of the first therapies we've had for reversing ocular surface inflammation. And so the information's been out there, but it's been hard to ever measure it on the average patient. Now we have a test like Inflammatory, which measures MMP9s, which basically this patient sitting in front of us, we can say where he's starting from baseline. And for me, I like to have that information before we even do anything or early in the process, and then measure change over time. If what we chose, number one, is not making the patient worse, or hopefully we see improvement. If maybe we can do a therapy that gets the patients off of eye drops. So I think now we have tools in the office that we can use to assess more on an individual basis versus all, to put use in conjunction with study data, which talks about the general problem, and then we can once again measure how effective our therapy. The same thing that we do in lowering intraocular pressure. We get kind of a baseline, then we choose a therapy and measure how well we did after the fact. So that's what's, I think, really changed, and it's in the hands of all eye care providers.
If I'm talking with a colleague who's beginning a practice or is interested in expanding their footprint in the dry eye space, we have a discussion that surrounds the available tools. Many of them don't have the tools yet, but they're very interested in acquiring. So things like Inflammatory become an essential part. Tear osmolarity, lissamine green, the basic elements for diagnosing and differentiating the diagnosis of ocular surface disease. The second part is to have them understand how that connects to their staff and how that integrates into the flow of patient care that they've developed over the years. And it can be a little bit of a disruption in the beginning, but once you attribute the concept and everybody's on board, it is really almost a seamless intervention to be able to run those tests and continue to see the patient for other and or additional testing in the glaucoma space. And then the final part is to understand how the billing and the coding takes place in order to maximize the opportunity for the clinician to provide an excellent level of care, but also receive the compensation that's reasonable relative to the investment in time and intellectual activity that is represented by having those elements in the office.
What I'd recommend is kind of developing kind of a basic treatment template when the patient first comes in. And I think it involves both testing for ocular surface problems with inflammatory, tear osmolality I think is good too, but also all the baseline glaucoma tests, OCTs of the nerve fiber layer, looking at tests that look at the angles, measuring pachymetry I think is essential in these patients. And then if they have some really disrupted surface, maybe we'll even get topography, which you never think about doing that in a glaucoma patient, but it really gives you an idea, especially if these patients were thinking about doing, combined cataract and MIGS surgery, maybe the treatment option that we're looking for. That can be really, really important information to have. So I think integrating these kind of baseline ocular surface inflammation tests along with our glaucoma parameters, just from the bat, that's what provides value to me. If I walk into the patient, I do my examination, And then I have these supporting information, which has already been acquired. That just makes it everything much more seamless and more straightforward. It's like, yes, my exam, concurs with that test. We don't have to doubt the diagnosis, and now we can move forward into the treatment kind of arm of things. And so that's what the value I see is these tools. These technology has given these tools to be more widespread, the acquisition of information to have from the patient before they even get to me in referral practice. And then we can use these same tools when we send the patient back for when we think they're more stable on the backside after I've done an intervention. They can use the same things in our office to basically continue to see how we're doing, both in terms of ocular surface inflammation as well as glaucoma control.
I think that the technology in the ocular surface space has been so pleasantly advanced and is so derivative of what we need to know and how we can use that knowledge to change our patients' outcomes, that it's really not a big choice. I think it's more of a matter of how to find the right space in the office, how to find the right flow, changing a little bit. It's not a big change in a busy practice. It's a very small change eventually. But it is something that the doctors need to first buy into the technology and say, yes, this is valuable, and I believe that asset helps me in my patient care. And then second to that, how do I fit it into the space, and how do we organize the process so that everybody benefits, both the patient first, the doctor second, and then the practice third.